if they're good, it's all about a reflection of the people who are on their faculty and who students have a chance to study with. And one of the great moments in our recent history of, of our school was the ability to recruit Pascal and more recently Michelle to leave beautiful downtown Geneva, Switzerland, and come to Los Angeles and really reinvent themselves and areas that are enormously important for all of us. Pascal was raised in Switzerland, went to the University of Geneva, and after graduating from school and looking around the world, he was able to get a grant from the Swiss government, which enabled him to go to the University of Minnesota and spent a few years with Bill Douglas in the Department of Biomaterials and Bioengineering to really get a grasp of the physical and chemical and biological implications of the emerging restorative materials that are existing and are continuing to evolve in dentistry. So this evening we have a sort of an update type lecture to get a sense of essentially over the first year of his career here at USC, what Pascal is thinking about, what he's doing, and how he's obviously attempting to influence what is thought, what is taught, and what is practiced in association with the School of Dentistry. Join me in welcoming Pascal Magne.
Thank you, Hans. Thank you for this nice introduction. I'm very honored to be introduced by the Dean himself. And just as a little note, even though I know you were a dentist only for a year, you told us when I was born, I've been trying to catch up with time, and at least with the top of my head, I think I'm very close to you now. The rest will come, I hope. So, okay, I want to share a little bit of what's been going on during this year spent with amongst you, and I want to focus a little bit on one specific topic today, which is the development of aesthetic restorations on posterior teeth. Of course, as I always had presented before, when I consider the university, the academia, and the field that I want to study, I always try to keep it cohesive in teaching, in research, and in patient care. And I like to have these three things always connected together because when you are isolated in one of these three, let's say, parts of the academia, I think the risk is you really lose connection with the rest, and maybe what you do is losing also a little bit of relevance. So that's why I think it's very important to me that these three things coincide. And again, as a little summary of what I've been trying to do during this year is influence maybe a little bit of what's going on with the teaching at the DDS level, where I have not yet really have a strong influence at the postgraduate level, because I wanted first to focus on the, let's say, the faculty and the teaching aspect, especially at the DDS level, and I want to share with you exactly what happened here. And we also started a few CE courses, and now more recently I'm so happy Michelle is here, because we have started also our first CE course together 2 weeks ago, and it's been very successful. This room was packed. We were almost overbooked. On the research type, I remind you that one thing that really attracted me at USC was the word biomimetics and the wonderful biological solutions that are getting ready, I hope, as soon as possible. When is it going to be? However, you all know that my motto is also that even, let's say we have these biological solutions available tomorrow, I think we will still need mechanical, let's say, corrections of these new solutions to have a tooth, a biomimetically made tooth that is adapted to function and aesthetics in the mouth of the patient. So that's why I think we still need to work at the optimization of mechanical solutions, which is also part of my activity. And finally, the patient care. We are working very hard at the Oral Health Center, as you know, with the Dental Technology Center that is being built there. So to help develop really the clinician dental technologist team, communication, and like really develop a philosophy for the patient care. And again, thanks to Michel and his team, I think that's going to happen now very soon. Okay, so I want to share, again, as I said, today I want to focus a little bit on the teaching of adhesive restoration in the lateral segment, because the other time I lecture for this series, I focused a little more on the front teeth and aesthetic in the anterior. And I want to share with you a little bit of the Geneva experience tonight, especially because I couldn't resist showing you that picture when I was a young assistant. With all my attributes present, and quickly, as soon as I became a dentist, things started to really get worse and worse. But that was in '89, and as I said, I just got my degree. I was a young assistant, and why did I have in my armamentarium? What was my tools that my school gave me with my DDS diploma? And in the restorative dentistry, basically, that was amalgams, self-cure composites, which were used in bulk. There wasn't any layering technique at that time. And I remember placing one single unit gold restoration during my curriculum. And then the rest was porcelain fused to metal, single units and FPDs, no implants at that time yet. Okay, and these, just for you, I found my, these are my amalgams I did for my final exam. Especially, I wanted to show that to all the faculty who believe I don't like amalgam. I loved amalgam as much as I love composites today, and I will show you other examples. Today, 2004, the curriculum has been growing, and we just keep adding to the curriculum, and I think really what we have to think today is there something we need to remove? Because we can't just keep making the bag heavier and heavier and think that our students can handle all these techniques. Not only amalgam, but now we have direct composites, lots of different techniques I will tell you today about. We have composite and porcelain indirect restoration, porcelain veneers. I didn't do one single porcelain veneers as a student, so now we have added that. Full ceramic crowns. There is a variety of different type of full ceramic crown. Plus, we keep going on also with gold restoration, which is also a very sensitive technique that requires lots of teaching and education. So that takes a lot on the curriculum, and we keep doing PFM, and now we have also the implants. Can you imagine how this has been growing over the last decade? And I think we need to really think about this. When this is some data that Rick's provided me from the 2002 USC preclinical teaching. About 100 hours was spent on amalgam, the same on adhesive restoration. 200 hours was spent on single unit gold restoration. It's been reduced just after to 100 hours. And then posteriors, FPDs, anterior FPDs, another 200 hours. I think that's very interesting to look at these numbers. What happened in Geneva, and I want to share with you some other numbers collected between September 03 and May 04, which allow me to compare. Of course, University of Geneva, just to give you an idea, one class of DDS student is about 15 students. Right? Here, a class of DDS is what? 144? Something like that? So just to give you an idea. And these numbers are not, let's say, prorated by the number of students. These are the real number of restorations placed in Geneva in that time. And you see that we have 1,270 adhesive composite restoration versus 23 amalgams. And when I ask the same number for USC, we are still placing almost 1,000 amalgams against these numbers of composites. As you can see, first of all, I'm really surprised how many restorations are placed by the little number of students in Geneva. But as you can see, most of them are today adhesive. Now, we need really to ask ourselves in this context, which I think is a little bit overwhelming for teaching. We can't have our students master all these techniques. Is really, what are they going to do in the next 10 to 20 years? And of course, I couldn't resist to tell you about the amalgam controversy, which is, to be honest with you, one of the first things I would try to really seriously look at in terms of, shall we maintain amalgam? I think, and this is my personal point of view, that amalgam is likely to disappear within a very limited number of years. We have ecological problems, disposal, environmental release of mercury, compromised aesthetics, but this is really not my first concern. I must tell you, I'm more concerned about the compromised biomechanics of, let's say, amalgam in particular, but all types of unbonded restorations. Cemented restorations like amalgam, for me, are in the same group in this regard. So, and we know that today we have improved substitute materials that have been really tested for now a number of years, and we have strong evidence that amalgam is seriously dying. And I think when I look at the numbers of hours that are spent on amalgam in our curriculum, that concerns me a little bit. So this is a review by Jean-François Roulet showing that, again, these numbers, that amalgam is not better for sure than the new substitutes, maybe worse. I will show you other numbers later. The annual failure rate is not different from that of posterior composites or from that of tooth-colored indirect inlays, which is ceramic and composites. The only thing is, of course, the numbers about amalgam, we have them for much longer because the technique is older, and that's no surprise. For me, the amalgam controversy is really the biomechanical issue is predominant because you see these very nice amalgams that were made by one of the best clinicians, our guru of amalgam in Geneva, and he's been a strong advocate of biology and amalgams. And you see that this is unavoidable, made in the best condition. These restorations do not allow the tooth to really recover their biomechanical strength. It's a slow process of cracking, and these teeth become very sensitive when this happens. It's the so-called cracked tooth syndrome, already shown by Cameron and in 1964 and later reinvestigated by Gersten. The cracked tooth syndrome is no different, in my opinion, even though some people in the audience might disagree with me, and I know Terry would be the first one, but biomechanically, as long as the restoration is not bonded to the remaining part of the tooth, we are exposed to this kind of failure, not of the restoration, but of the tooth. And that's really what concerns me. This is another example, and I have tons, and I know you see this in your practice every day, these amalgams and these teeth. You remove the amalgam, it's full of crack everywhere. Most of the time there is a sensitivity already. Other example, this is an occlusal amalgam, very badly made in this case because there is a huge recurrent decay, and when I just touched that cusp with the burr, it fractured away. There was an existing crack down there. So again, I think we need to think about this process. The worst that I've seen is this, and that's been really the antithesis of what we are trying to do today. This is pure mechanical retention and stabilization, and I hope we don't see that again and never again. So the revolution really started when we started to understand that cusp can be reinforced by the acid-etch technique, And that was for me one main reason, this fantastic paper published in Minnesota when I had to decide where I wanted to spend time on research. That was one paper that was like a little indicating sign for me where to go. The revolution, the silent revolution of adhesion has grown a lot since '84. Lots of things have happened, and I want to share with you today. As I said, in Geneva, we started the conversion in 1992. Zurich started this conversion even well before. And as I said, in 1992, it was quite funny because we didn't have a real concept, a philosophy. We were trying to adapt ourselves to these new possibilities. This is a case I did. You see the base lining of this cavity is made with zinc phosphate. I will show you a long-term follow-up of these cases a little later. And I was still very passionate about amalgam and function, as you see. And I remember I was very much inspired when Michel, I was still a student, and Michel had followed a conference by Harold Chavel about amalgam. And it's funny, the Journal of Aesthetic Dentistry is republishing one paper of Harold Chavel with this beautiful, beautiful sculpture, and that inspired me a lot. And you see, my brother was already teaching me dentistry as a dental technician. So these are cases I did during these years. I couldn't recall that patient, unfortunately, but I had at least a 4-year follow-up of that case that we had published, the very fun layering technique that we can apply to these restorations. And again, this was made with the very bad knowledge and technology we had during these years. And I will show you more follow-up now. This is a case after 7 years, a direct MOD restoration because there was decay under these crests. And this is the longest follow-up I have on my restorations. It's 13 years of this MOD. Actually, it's a lingual occlusal distal restoration. You see the margin here. And in this case, this is an inlay restoration in composite. 13 years in the mouth. Again, the bonding to this tooth was much less than optimal. We bonded to enamel. Essentially, there was no internal bonding to dentin in those years because we were rather isolating dentin by fear of biological damage to the tooth. And this is where we came today, and that's I like to show this example as one of my DDS students did that just before I left Geneva, and that was a compromised tooth with a very deep margin in dentin on the distal aspect. And in this case, we approached that tooth with a completely different way. We would expect to be done using the traditional prosthodontic principle. That is, this deep margin was raised using a direct composite application. We know that if we can place rubber dam, if we can place a matrix, and if we can isolate very well the margin using the matrix, the rubber dam, because composite you don't need to condense them, you can apply them very accurately and simulate somewhat the cemento-enamel junction again here. And then we prepped, within this composite, we prepped an overlay preparation. Of course, there was a new endodontic treatment that was made. We basically kept as much as we could from the remaining tooth substance. Now, there are still lots of questions that are unanswered by the current body of evidence, as, for instance, should we cover or not this type of remaining enamel, which is very poorly supported by dentin? Can bonding restore the biomechanics of this part of the tooth? And my guess, and I will show you more research about that, is that the restorative material that we choose here is going to be critical in that regard. Composite versus ceramics. So this is the restored tooth with also the restoration made by a young dental technician in apprenticeship at the University of Geneva. That's the baseline. That's the finish line of this tooth. No post and core build up there. Use of a light curing material to bond that overlay on that tooth. So So let me tell you a little bit what happened, because when I came at USC, a lot of people wanted me to just jump into the student clinic and teach. And I was very afraid to do that, because I had no idea about what was being really made in my discipline at USC. And I think that knowing the long tradition of USC for gold restorations, and also looking at the curriculum and the time that is spent on amalgam, I decided to have a different approach. And I decided to form a small group of faculty being inspired by the PBL approach, let's say, and have an evidence-based evaluation of the curriculum. And first really agree on what is the current state of the art in adhesive restoration, and have this small body agree on what we want to do, and then use this small group to spread the so-called gospel of adhesive dentistry with the most rigorous unity of doctrine possible in that school. Because it's very easy today in these fields to have lots of different concepts, materials, techniques are jumping into our face. The market is growing crazy, so we need to be extremely rigorous in what we want to teach. And so we started this small group. We opened to almost all the faculty, right? Rick Kahn helped me form that group. And basically the people you see here are the people who responded and said, yes, I want to be part of this story. And but again, most faculty of Division 4 were invited to join. And so we did, the process was, we started literature review sessions, again, to explore the current state of the art in science and clinical application of this material. And we reviewed the curriculum. We then made recently a small group hands-on experience to not only read articles, but also see what is the practical aspects of all these discoveries. And we are currently working at step number 4 to have kind of a student manual, like I like to call it a little Bible of adhesive dentistry, adhesive and biomimetic dentistry that will be available to the students. And the next step, once we have established really our doctrine, is then to really spread it to the whole faculty, at least starting in Division 4, and have a large-scale hands-on for all the faculty before we start really going into the student clinic and maybe preach, every of us preaching something different that can create a lot of confusion. I think we first need to all agree on what is going to change. And so the manuals are under fabrication, and we are having regular meetings to agree again on the exact contents that we want to include. And I want to share with you a little bit of these, the result and the fruits of all these reflections now. So basically, when we talk about the posterior restoration, adhesive restoration on posterior teeth, we can group them in 3 different categories: the direct, the semi-direct, and the indirect techniques. And I want to go one by one now. Again, I want you to know the driving force, and I like to really state that from the beginning. The driving force is really not aesthetics. Aesthetics is definitely my last concern. It's a gift that comes with the concept, but it's not the driving force. The driving force is that we want our students to be able to face what I call the plethoric dentistry, the enormous amount of concepts that is out there in the dental world. Clinicians, technicians are faced with difficult decisions to choose, to select adequate materials, and these doesn't decrease the treatment costs overall. So I think the core foundation is to rationalize dentistry, to have concepts that are looking at the same unchanging reference. And what is the reference? Of course, it is the natural tooth. It is the intact natural tooth. The dream is that the restored tooth should not only look like an intact tooth, but it should function, it should be biologically respected, that's very important, and the mechanics, of course, should be very close to that of the intact tooth. And I must tell you, if we respect biology, if we copy mechanics, if we copy function, aesthetics is automatic. It comes with it. You can't separate aesthetics from the rest of it. And I like to call this the biomimetic principle, knowing that biomimetics is really something that is at the biological level. The biomimetic principle being, let's copy the tooth with what we have today in our hands. Before we can have these artificial tooth parts that biomimetics will give us, we still have to deal today with replacing the missing tooth part, and let's use this biomimetic knowledge to copy nature. And that's really the goal. Copy these beautiful intact teeth and understand how they function. And again, I like to state that from the beginning, so we all agree on that. For me, the goal of the biomimetic principle is to return all the prepared tissues to full function by the creation of a hard tissue bond. There is no way you can apply biomimetic dentistry without hard tissue bond. So it's all about adhesive dentistry. And that will allow the functional stress to pass through the tooth, drawing the entire crown, the remaining tissues, into the final functional, biologic, and aesthetic result. And if we do that, I can guarantee the result will be that we will use less and less of these old mechanical stuff like the intraradicular post, and full coverage cemented crown should slowly disappear from the armamentarium if we apply these principles. So let's look at this classification of techniques, which is actually absolutely not new. We published that in '96 with my colleague Didier Dici, who came here and gave a continuing education course. I hope you had the possibility to follow. And basically, here are our three possibilities: direct application of material directly in the mouth, semi-directly, which is during the same session, but some steps can be done extraorally, and then indirectly, where the restoration will be fully fabricated in the lab. So let's start with the direct techniques. And again, what is the dilemma of the direct application of adhesive material in the mouth? The dilemma is the contraction and the polymerization shrinkage of these composite resin that are going to pull on the remaining cusp and create all sorts of problems. And all type of solutions have emerged to try to compensate for this problem. But you can already understand that the smaller the cavity, the smaller the amount of material that is shrinking, the smaller the absolute amount of shrinkage and relative problems. So these indications will be restricted to a certain size of cavity, and when we reach a bigger size, we should go to the next step, which is the semi-direct or the indirect technique. All kinds of layering techniques have been developed to try to compensate for this shrinkage. This is what I think most of us would agree as a perfect indication for direct application of composites. It's already a good size cavity. Much more than that would not be indicated because of these shrinkage issues. So what's going on in the market about these concepts? And you will hear about the use of a flowable elastic liner to place in your direct cavities so that it will compensate for the shrinkage. Let's look at this concept. I will show you some data. What is the effect of the placement technique? These are all very important questions. The effect of the preparation margin finish line, beveling the enamel, for instance. And let's look at some tools. There are some new tools that are very interesting to be implemented in the practice. So again, flowable liner, can we reduce the stress and, let's say, the degradation of the margins of our direct restoration using an elastic layer that will deform and absorb the polymerization shrinkage? according to the literature, it's not really very cohesive. It's not very a concept that is accepted by everybody. There is really no evidence of the ability of buffering stress by these composites, these flowable composites. The reason is that because they are flowable, they have more resin, they have less filler, and they shrink more. And unfortunately, the shrinkage is not compensated by the lower elastic modulus of this material. So they still give more problem of micro leakage compared to conventional composites. What about the placement technique? The placement technique, we know, has been influenced by something called the C factor, which is the ratio between the bonded and unbonded surface of the restoration. And we know that when the C factor increases, we have more problem of stresses. And that's why the common sense is telling us that C factor can be reduced by different ways, and sectioning, incremental buildup is usually agreed by everybody. A bulk, we should not fill a cavity in bulk. That is going to create more shrinkage and more problems than if we do incremental building and we segment the cavity in smaller increment, and there is less shrinkage. Also, researchers agree more or less than a horizontal layering technique in 1 millimeter increment is working very well. There's another thing we can do to minimize the shrinkage is to delay the gel point of the composite. The gel point of the composite is the moment during shrinkage when the composite starts to develop an elastic modulus, and it starts really to pull on the margin. And we know that we can influence more or less the chronology of this development. And the more the elastic modulus is delayed, if you want, the less stresses we will have during shrinkage. And this is, by the fact, very well known in the case of chemically cured composite. We know that when composites were chemically cured, the gel point was delayed because it's a much slower polymerization process. So common sense is telling us that when we cure composite, the use of very highly powerful lights and very fast polymerization doesn't make sense in that concept. And that's why lots of techniques have been developed, like the slow start or pulse delay polymerization technique that uses very low intensity at the beginning and that raises at the end. Now, the common sense is also telling you that if your cavity is too large, just go to the next step. Go for semi-direct or indirect. About cavity margin preparation, what's the effect of a bevel on the performance of these restorations? Again, here it's not really too difficult to understand that, and we know that from different studies, the orientation of the enamel prisms is very important in the quality of the bond. We bond more efficiently when the prisms are sectioned transversally, and the bond is much weaker when we bond to longitudinally sectioned prisms. We know that in the occlusal surface, because of the angle of the cusp, our marginal finish line is usually crossing the prisms transversally, which gives very acceptable bond value. And if you look at the data in the research, you won't see beveled occlusal cavities perform better than unbeveled one. It's very similar. Beveling the occlusal surface will help you a little bit with the aesthetics, because you will have a smoother transition from the restoration to the rest of the tooth, and that will help the aesthetic integration for sure. In the cervical, it's completely different. The orientation of the prism is really telling us that if we don't bevel, we will leave a lot of really unsupported enamel, and plus we have more risk to section them longitudinally in that area. So it is usually agreed that proximally a bevel is recommended, and that occlusally it is not required but recommended for aesthetic reasons. Now, this becomes really problematic when it comes to the practical realization, because we all know that the bevel is really the the beveling of the proximal area is really difficult to do with rotary instruments. And there is a very interesting study that was made in the Netherlands where general practitioners were given a Frasaco model and were asked to prep and bevel a proximal class 2 cavity. And the results were disastrous. When they were using burrs, 80% of the approximal surfaces of adjacent teeth were damaged. And these were practitioners. These were not young students or beginners. So this is a serious problem that's been outlined by different studies well before that one. That study is interesting in the sense that a new tool was investigated to prevent that problem, which is an oscillating tip technology. These instruments, they don't rotate, but they vibrate at a frequency of about 6,000 hertz. There are different types, 6,000 or more according to the technology. These are sonic tips. There are ultrasonic tips that vibrate much, much more. And again, when these tools were used, the damage to the neighboring tooth was reduced to 30%. And why, you are going to ask me, why still 30% is damaged? Because the tools here were used only to do the bevel part of the restoration. The rest was still cut with burrs. So burrs are really difficult to handle in the proximal area, and I think we must be honest, none of us can guarantee he can prep a perfect proximal cavity without touching the neighboring tooth. But again, I think one significant progress is this oscillating technology. I was discussing with the dean before, the way we cut teeth has not changed for so long, forever. And finally, we have a tool that is innovative, and I think we should implement that today. It's a significant development. The system I like to mention is from Kevo. It's called Sonic Flex, Sonic Sys. It's actually an air scaler that plugs into your air-driven connection. And Kevo was very creative to fabricate all sorts of tips that can adapt to all the situations you can encounter in the clinical field. And I want to show you some examples. This is called the hemispherical tip. This is the large one. They have a small one. You can cut with this tip micro cavities for very small decay in the most ultra-conservative way. And if you leave, basically what is recommended here is to cut the proximal cavity without removing the enamel wall. And you keep the very thin enamel wall intact, and then you go with this instrument and you finish the proximal aspect, and you can have a very clean cut. Another instrument that is really nice is like a cone here with a 45-degree angle, and this one will make a perfect bevel of your enamel, as you can see here, with absolutely no risk of touching the neighboring tooth. I think this is a great tool we really have to implement. In the proximal management of the proximal area, another very common problem that was reported with composite at the beginning was the development of contact points, because composite, we don't pack them, we don't condense them, and for this reason it's much more difficult to get the contact point compared to amalgam restorations. And we know that with composite, however, whatever the stiffness of the composite, the packability of the composite doesn't change anything, because it's still too soft to be condensed. What is really going to make a difference are some innovative tools like sectioned, contoured, burnishable metal bands and separation rings. These have proved really this is one example of a study who proved that these tools allow to compensate for the problem we had due to the floppiness of the composite when it's still uncured. And this is an example. This is the Garrison dental solution. It's again a ring, a very stiff ring with these sectional matrices. And basically what the ring is doing with this little step here, it's pulling teeth apart very, very strongly, and that gives well enough strength to develop the contact point. I couldn't resist to show you some beautiful amalgam restoration here, but fortunately replaced with adhesive ones. So in this one, I did already the composite, and you can see, I will show you we can have a lot of fun, and we share a lot of happiness with Rick when we build these ridges, this stain. We can stain the groove, and you need to be careful when you stain the groove that another dentist will not believe it's a carious decay and start grinding. You are laughing, but this happened in Geneva back 10 years ago. One of the professors started to grind a rest for a removable prosthesis, and he started grinding in the rest here, and he thought that was, and suddenly the carious decay disappeared in the composite, but then suddenly there was zinc phosphate under the restoration, and he was very upset. He didn't know it was a composite restoration. So you see here the ring is really pushing, so these two parts tend to go together, and they wedge the teeth very strongly, and it gives well enough force to get a good contact point, despite the fact that we can't really pack the composite. And as I said, it is, to me, these direct composites have changed the way I practice, in the sense that it's fun. And I think we must have fun in the way we do dentistry. Otherwise, why do we do that profession if we don't have pleasure, if we don't really enjoy what we are doing? And I must tell you that when I graduated in '89, to me, dentistry was not fun. And I was frustrated, and I think some of you know the story. I was almost going to go back to medicine and study medicine and go like in surgery or something like that, because I was not excited about placing restorations that were not making teeth look like intact teeth. And when I started to do adhesive dentistry, and when I started to bond this beautiful porcelain restoration, and when I started to do this layering technique, suddenly that changed the way I was looking at my work, because now I could look at it and say, where is the restoration? And later, when I did my biomechanical studies, I could not only look at it with my optical eyes, but I could look at it with my tools, with my testing machines, and make a strain gauge measurement, and realize that not only they look good, but they function good like a tooth. And that's really, I think, what is exciting. Now, about directly placed restoration, of course, it is not recommended to do a restoration of that volume using a direct placement, because we know that this is going to be too much shrinkage. People in Minnesota, my friend Anthony's made a wonderful study where you could actually visualize the amount of cusp deformation that is engendered by the shrinkage of these large restoration, and it's a very, very large deformation that can happen here. So other people did finite element study, and they show for this kind of volume it's really recommended, even though it seems to be a good configuration factor with lots of unbonded surface that can shrink. Still, you are creating lots of stress on the margin of these onlay restorations. And this is why the semi-direct and indirect techniques were developed. And the semi-direct techniques are very interesting because they are kind of making a large cavity affordable to the patient without need of using maybe a lab, or without need for making two casts, mounting an articulator, a lot of expenses. Why do that when we can maybe do a single restoration with a simplified way? And different techniques were proposed here. The first one was the direct inlay. Why not using the cavity itself as a die and fabricate the restoration in the mouth? That was a very smart idea already in 1984. I think that's a German fellow who had this idea. And I used that. This is even my wife's tooth, on which I used the technique of the direct inlay. She had this temporary material we removed, and that's really ideal for a direct inlay. Why? Because it is a very simple geometry in this case. There is the contraction of the resin in the mouth will not really lock the restoration into position. So that's really nice. At that time, I did that one exactly 10 years ago. And that's why I'll show you this one, because I'm going to show you how it is today. But that time, bonding to dentin, we didn't look at that. We isolated. So I was either using copalite, or in this case, what is that? Zinc phosphate, the good old medicine, right? Terry is happy. So you can still use zinc phosphate today if you want, because it seems to work. And again, we don't know how much dentin bonding we need under this restoration if we have excellent bonding to the margin. So in that case, I was using Vaseline, a matrix, build up my composite directly in the mouth, then pop off the restoration, and do a post-curing process, because also at that time we believed that the conversion rate of the material would be improved. The total shrinkage would be achieved in a few minutes by this heating process, about 5 minutes at 100 Celsius, which is 212 Fahrenheit. We knew that hardness and wear resistance would be improved, at least demonstrated in vitro. What is obvious today is that clinical studies could not really show if the post-curing is really essential. So basically, the semi-direct technique is useful to allow this initial big polymerization shrinkage to happen freely. For sure, that helps. Now, if the post-curing is really determinant, we don't really know for the clinical performance. What you need to be careful when you do a direct inlay in the mouth is that with multiple surface restoration, the inlay can lock into the cavity because of the shrinkage. So you want to use a very tapered preparation, very simple cavity design, and now there's a new insulation medium which is like kind of a latex liner that you can put in the cavity. It's called rubber set by Kerr, and it gives more compliance for the shrinkage to happen. And then you take the restoration and you bond it to the tooth. That time I already was using a light cure restorative composite as a luting agent for this restoration, etching the marginal enamel, of course, and also roughening, surface roughening the internal part of the restoration to get bond to this composite. And that was immediately after placement. And this is now, I apologize for the bad quality of the picture. This is 10 years later. You can see the margin here of the restoration, and that's not by the fact you are just thinking, but where is that tooth coming from? It's a biomimetic tooth that Dr. Slavkin gave me for Christmas last year. No, it's her second molar that was mesialized by orthodontics, and by the fact this also a large composite, occlusal composite restoration. These are other examples, very simple cavity design. Inlay is layered in the mouth and then retrieved and re-cemented. I would be careful teaching that to the students again because of the risk of locking the restoration. Layering the restoration in the mouth is still as difficult as it is for a direct restoration, and that's why I like very much the next technique, which is called the semi-direct extraoral inlay, in which we take a small impression, and it can be an alginate impression of the cavity, and we have a fast-setting silicone model. These were the first generations of this fast-setting silicone that you can fabricate in minutes in an alginate impression. It's not like stone, you have to wait, and it's difficult to section the model. Here you can section the model with a blade, and then you fabricate, you layer, you put in the oven, you post-cure, and you can place in the mouth. I did lots of these cases about 12, 13 years ago, and I was very excited about using stain. I discovered staining, and as you can see, I used a lot of stain, a little bit too much, Michelle, you would tell me. But that was fun. That's a before-after case, and this one you saw, it's exactly the same technique, semi-direct extraoral restoration. Today we have a different type of silicone. This one is really nice. Again, an alginate impression is extremely accurate. I can tell you, alginate is fantastically accurate. You pour that little model in about 3 minutes. You are ready to work. You use there is a little base that is supplied by in the Mach 2 system blade. You section the model, and you can adjust perfectly the composite in the proximal. In the proximal contact, marginal adaptation, you layer, this is like dentin-like, enamel, stain, a little less stain today than in the past, and then after placement in the mouth. This is one of my first cases here at the faculty, at the Oral Health Center. That's another example. Here we have a cracked cusp, you see here. So in that case, we decided, because it was so thin, we decided to overlap that cusp with the restoration. We still decided to go with composite, so the shade was a B2. We go with a little more saturation inside, a little bit of opacious dentin to mask this very strong staining here, and then build up the ridges in enamel, a little more saturated in the center, and then a little bit of stain, of course, and then the ridges one by one. You can build the ridges and do a nice, very nice anatomy. It's much easier because it's on a model and it's not in the mouth of the patient. So you can develop a very nice layering and accurate anatomy, then post-curing again, and final placement. Extremely accurate. I must tell you, these are the most accurate, indirectly made restoration I've ever placed. They are so easy to bond because the marginal gap is minimal. That's, again, a before-after picture of that case. Now, CEREC. What about CEREC? Finally, CEREC, if you look at it, belongs to the semi-direct technique. It's really a technique that you don't need usually a provisional restoration to do a CEREC. So it's really the semi-direct. It's in part extraoral, in part intraoral. I did one case with CEREC since I arrived here, and it was a nice indication because the patient actually had a very deep decay here. It's not visible on the X-ray, but ultimately we had to make a root canal treatment. And I didn't want to make a crown, as you can guess. So I did a CEREC overlay in which we don't need a post and core build-up, nothing. The mesial margin was ultra deep, which I raised with a little bit of composite directly placed. And then we fabricated the CEREC restoration. And so why I'm showing you that case, because CEREC is wonderful. CEREC is amazing tool. But I'm very disappointed with the final outcome, because you put a lot of energy in that. On the screen it looks beautiful and 3-dimensional, but once you have your ceramic block that is milled, it looks very gross and very simple. And I can tell you, this is a good one in terms of shade. It integrated very well, as you can see. Now, the patient that looks only at the bad amalgam on this tooth. It doesn't look here, even though this restoration is far from being like we would like it to be. The amazing thing about CEREC and CAD-CAM, but when we say CAD-CAM with 10 years of follow-up, there is only CEREC that we can mention. It's that the survival of this restoration is the closest that's been documented. It's the closest to gold. That's quite surprising. So now it's interesting, Terry, because we have the two opposed philosophy that are showing almost the closest survival rate measured clinically. And as you can see, I don't want to spend too much time here, but amalgam is definitely the last one on the list with 3% of annual failure rate. What is also very interesting from this study is that definitely indirect restoration show, which are adhesive inlays, better survival than directly made amalgam and composites pooled together. So again, we want to consider this semi-direct technique because they have all the advantages of indirect techniques, and they are not so costly like indirect techniques. So I hope we can implement that in the student's clinic. And finally, I want to finish with the indirect technique, and now you can guess. Indirect techniques are really recommended when you have a large number of restorations, unless you do one semi-direct inlay at a time, which is fine. Why not? But if you want to do serial restorations, then you need to have full casts of the arches, mounted an articulator, and this is the only way to have a control on occlusion. And now we have the choice for ceramic or composite, but recently during our faculty aesthetic update curriculum, we decided that if we want to go indirect and we have cusp coverage, we really want to favor the use of porcelain. And if we have an intracoronal restoration, again, evidence-based, I will show you some data, is not available to say porcelain is better than composite. We have some signs that porcelain is maybe better. But of course, it's also going to be at a significant difference of cost. So these are examples of serial indirect restorations made in composites. And in this case, you see it allowed to maintain also these remaining cusps. We don't know, as I said, is it really indicated to cover that cusp or not? I want to show you some data. If you cover these cusps, actually you strengthen the tooth significantly. The problem is when we strengthen the tooth too much, when it fails very badly. And so my assumption today would be keep these, even these thin cusps, keep them. The worst thing that could happen in that case is a local failure of these remaining enamel ridges that is so easy to repair. Now, again, the dilemma composite versus porcelain. What do we have in the literature? Very little to say if composite is better than porcelain for these intracoronal restorations. This is in vitro fatigue testing made by my colleague Didier. There was no difference in marginal and internal adaptation of these inlays. Another study here in which they measured the number of chewing cycles to failure using 170 Newton of force, and again, a very difference to see a difference between ceramic and composite inlays. But very interesting in this study, they use a very small number of samples. I don't know how it could be published with only 10 teeth being tested in a load to failure test is really a small number. The interesting thing is that on the 5 ceramic restorations, 3 of them did not fail after the test. While on the composite restoration, as you can see, all of them failed after the test. There was failure obvious for all of them, but statistically not significant. But still interesting. There is a trend that ceramic is more able to stabilize the cusp and more able to maintain the biomechanical integrity. This is another study now. It's a clinical study, 3 years. It's very short, and using USPHS criteria, 100% of acceptable porcelain restoration versus 89% for composites. All failure, basically what comes out from this study is that the failure is more likely, whatever you use, composite or porcelain, is more likely to occur on molar. And also from this study, significantly better anatomical form of the surface and integrity of the restoration for ceramic inlays. Maybe, I don't know if you agree on that one. There is not much data on that. This is one study, and I think we need much more data to show these differences. This is another study, again, an in vitro test, 50,000 cycle at 50 newtons, and then a load to failure. And in this study, there was a trend again for more marginal defects for composites, less cuspal protection. We know that composite is not an enamel substitute, it's more a dentin substitute. Porcelain is stiffer and more enamel-like. So when we replace a large amount of enamel by composite, we can expect that there is less tooth-like behavior, and ceramic will give you a more tooth-like behavior in terms of biomechanics. We studied a little bit that with finite element in a 2D model, comparing inlays and onlays and the different materials, and I can tell you not much difference. What is really different is an inlay versus an onlay. And that was really interesting because an inlay restoration actually gives a lot of bad stresses in the interface of the restoration. This is the stress at the interfacial bond. And inlays actually have lots of tensile. You see the zero line is here. Everything that is up there is tensile stress. Lots of tensile stresses on the bond. While when you do an onlay restoration, most of the interface is under compressive stress. And that's why the onlay type restoration is a very strong concept. Maybe the bond strength in these cases is not so critical because most of the time the interface will function under compression, while the inlay is a more critical area because there's much more tensile stresses at this interface. When you look at the difference between composite and ceramic on the onlay type restoration, and this is really the beauty of finite element, is to compare side by side this material, you can understand that there is more floppiness, there is more cuspal deformation with composite. However, on an onlay restoration, the bond is mainly subjected to compressive value, the gray area, or very little tensile stresses. On the porcelain, you see the interface is almost only compressive. What is the effect of cusp coverage? I told you, if you cover a cusp, like even if you do that with composite, like in this study, you are increasing significantly the strength. And in that case, the design B in which the buccal cusp was covered gave much more survival in that test. And that test was basically, again, a number of cycles until failure using a ramp loading, a higher load, a progressive higher load during the cycling test. So again, if you cover, you strengthen. However, when these samples, the B group, when they fractured, usually there were much more fracture below the CEG. And that's more difficult to restore. And that's very important. That's very good. I like this study, and I would like to reproduce that once we have the tool to make these artificial chewing. Then we can study exactly how teeth can fail with the different scenario. Now you see this is a tooth with a complete coverage. In that case, a non-vital tooth, restored with a large composite restoration. And as I said, the protection by the cuspal coverage is here. However, when failure occurred, it was a catastrophic failure. Again, on non-vital teeth, my belief is that the cusp stabilization really needs a stiffer material, like porcelain. But again, we don't have the answers to that questions yet, to these questions. And in the indirect restoration, the last group of patients I want to show you are these complete coverage, so precisely cases like we saw before, these complete occlusal coverages with minimal amount of stabilization and retention, something that we are not used to if we use the traditional prosthodontic approach. And I want to show you some other example. So cusp coverage, as I said, we are going to recommend more of porcelain use than composite, even though we don't have yet a strong body of evidence to show that. I want to show you that example, which is an old case I did, again at a time where dentin bonding was not at all popular, and it didn't work. So I was using at that time, sometime copalite with calcium hydroxide, sometime zinc phosphate. In that case, I had very little enamel left, but I used that just to bond my overlay, because I said, anyway, this tooth is so short, if I want to use a crown, a regular crown, I will need to devitalize, maybe do a build-up, a post, a core, and I don't want to do that. So we took this risk, and that was actually 8 years ago. This picture was taken at 5 years, but this restoration is still in the mouth today. There is no bonding to dentin. There is very limited bondage to enamel. And the reason, my assumption is, most of the interface here is under compression, even during function. So there is not too much risk. That's another example. Amalgam replacement, we overlapped also the cusps in that case. Very simple preparation. In that case, zinc phosphate to isolate dentin. And Michel did this beautiful layered overlay. And this is now a picture after 7 years, but it's been exactly 10 years. I'm going to see this patient next week. I'm going to Switzerland to recall most of the cases and have a new evaluation. So you see basically the gain of intact substance preservation given by adhesion. If you compare the PFM or any type of cemented crown versus the overlay preparation. That's my oldest case of this overlay. And this one, as you can see, was with a copalite and bonding only to marginal enamel. We had published that case, and now we have 10 years of follow-up. That's in 2002, the same overlay that I placed in 1992. There is no bonding to the underlying dentin. An interesting clinical study by Bargy and Berry showed, it's a 4-year report with these onlays, showed 100% of retention, no marginal discoloration, no G-chink carries, sensitivities. It's a very safe restoration, to say so. The only thing that really I do different today, of course, is the dentin bonding, because we know that today we can bond to dentin very efficiently, which increases significantly the prognosis of these restorations. And we need to know that when we bond to dentin, using an indirect technique, we have to be careful, because dentin cannot be left exposed to the oral environment during the provisional stage. And this is why we learned recently, and we are doing actually some research now on that the dentin must be sealed straight away when the cavity is prepared. And so, because dentin must be sealed when it's freshly cut, uncontaminated. It's best for adhesion. It will allow you to also cure the adhesive resin, which you can't do if you don't seal dentin at the time of preparation. But if you seal dentin at the time of final cementation, you are not allowed to cure the adhesive because the restoration will not see it otherwise. So it allows you to pre-cure the adhesive. It protects the dentin during the provisional stage from sensitivity, from bacterial infiltration, and the final bonding can be made without anesthesia because dentin is already sealed. So please seal dentin straight away when it's cut before you take your impression. Studies show better bond strength to the sealed dentin, that's the red bars, and studies showed more cohesive interfacial aspect under scanning electron microscope. This is when dentin is not sealed immediately. The bond detached from the overlaying composite during polymerization shrinkage, and you lose completely bonding. If you seal dentin, that's what you are going to see, a completely closed gap. Other studies, confocal microscope, show that resin-coated teeth, the so-called immediate dentin sealing, is able to almost close 93% of the gap, while if you don't seal dentin, you have completely opened internal interfaces. And excuse me. And just to make a summary of dentin bonding, don't believe that the latest generation of bonding agents are better. Actually, the standard is still the 4th generation adhesive, which are the only one that give consistent and stable bond strength to enamel and dentin. And I want to show you an example of these old 4th generation product OptiBond FL, which is old, let's say almost 15-year-old product, is still a golden standard today in bond testing. So it's a 4th generation 3-step etch and rinse adhesive. The good thing about this material, it's filled 50%, and it's a golden standard. Make a Medline search on OptiBond FL and find one paper that doesn't give you OptiBond as a 1st or 2nd place quality bond in these studies, either in vitro or clinical. And it was marketed in the early 90s. That's amazing. It's the least technique sensitive, this 4th generation. It's insensitive to shrinkage stress. That's really interesting. To the C factor, insensitive to the C factor, and to aging. We have one study, this one, show that after 1 year, the bond strength is still maintained. And so recently we started an interesting test together with Terry and Kim because we received a piece of equipment that allow us to test very accurately this bond strength to dentin. And what it is basically, we cut extracted teeth, we cut them flat, and we do these overlay restoration. And this is a very sensitive test because then we can segment these in small beams. And when I say small beams, these beams are less than 1 millimeter wide. So you have dentin on one side, you have composite on the other, and then you place these beams in this device and you pull with pure tensile force. And it's called micro-tensile testing. And the force you need to break is between 0, if you have bad bonding, and 7 kilogram of force on this little 1 millimeter square sample. And the results are very, very interesting. We tested direct bonding, which is like you do when you do a direct composite. You cure the adhesive and you place the restoration immediately, versus indirect bonding without using immediate sealing or with immediate sealing. And I tell you the difference is huge. If you don't seal dentin immediately, because the adhesive cannot be cured, because dentin is contaminated, you lose completely the bond, and 100% of these samples failed adhesively, as you can see here. While we had most of the time cohesive failure in dentin when we sealed dentin straight away, and we used this existing adhesive layer as a bonding layer during the final placement of the restoration, so cohesive failure in dentin. So really what is recommended today is when you are done with your preparation for your indirect, you freshly cut dentin, you etch, you prime and bond, you suction the excess of water always before you use your prime and bond, you never blow air to avoid the collapse of the collagen, and then you cure the adhesive, very important. You take advantage of the process to block maybe some undercuts because of these existing cavities, and then you can cure the composite that you use for blocking the undercuts. You air block with glycerin jelly and cure again to avoid the inhibition layer on your adhesive, and then you just clean the margin and you are ready to take your impression. And you do that before taking impression. That makes a huge difference, and that's the last case I'm showing you today, a case where we removed 3 old restorations with recurrent decay. Excuse me, that's before cleaning, after cleaning the decay. Then we etched dentin, we applied a primer, we suctioned the solvent from the primer, we applied the adhesive resin to the cavity, and you see I still have lots of undercuts. So I'm going to now fill the undercuts with composite resin, cure the resin, all the undercuts are filled, and now I air block the surface of the resin, I cure again to avoid the inhibition layer, and I finish the margin with the oscillating tips in the proximal, burrs in the occlusal, and you are ready now to take your impression. And I think the sun has set on Santa Monica, so it's time for me to stop. Thank you very much for your attention.